Okay, I think we have most of the colleagues here. Good morning, professors, students, colleagues, and friends. Thank you for coming and support our SCAN 2030 lecture series. So today is actually our lecture series 3. We're going to talk about value framework for building our next generation HTA. I'm Shirley, assistant professor from Hong Kong U, Faculty of Medicine, Department of Medicine. So on behalf of the SCAN 2030 team, thank you very much again to coming and support our events. And so this is the agenda of today. We're going to have 2 speakers, Professor Manuel Espinoza from School of Public Health, and also Dr. Tina Wang from CERES. They're going to talk about HTA newly development about value-based framework and what we have learned from existing HTA agencies. And follow that, we're going to have a short panel discussion, and it's quite freestyle. So this is going to be moderated by Victor from our Hong Kong Foundation. Hope everyone will have a very fruitful morning, and someone is online, so I believe this is their evening time. So hope there will be some takeaway for new areas of HTA, and I hope we can contribute to the development of HTA in the region. All right, a bit of introduction for those who is new to SCAN 2030. So please allow me to introduce a bit more about SCAN. So SCAN, the full name of SCAN is here. So horizon scanning of medium and long-term burden of chronic disease and care needs to 2030 in Hong Kong. The nickname is SCAN 2030. So this is actually a joint grant funded by the RGC Research Impact Fund. And RGC is the government funding, and with co-matched funding from Hong Kong Association, Hong Kong Pharmaceutical Association of Industry, Hong Kong API, and also matching fund from Hong Kong UMed. So this is a true engagement between academic, industry, and also the research teams, potential stakeholders to culture horizon scanning, forward-looking healthcare preparedness in Hong Kong. And in SCAN, we have a few objectives. So we're going to use real-world data and the decision analytical modelings to guide transparent and evidence-driven decision-making, particularly for innovative medicine adoption to the local system. And we're also aiming to, in the long run, we're going to culture our local talent to culture the ecosystem of HTA in Hong Kong and the Big Bay Area, and also developing more data-driven evidence for decision-making. So this is our long-term vision, and SCAN is now 2.5 years old. And since it's just the beginning, so we see a lot of involvement of SCAN. And basically, SCAN is working on 2 domains of research. The first part is about horizon scanning. So horizon scanning is about forward-looking to know what we have in the pipeline of innovations. So we do systematic global pipeline review to understand what is the existing innovations in the clinical trial stage or almost to the market stage to prepare the healthcare system. We also use local data to understand what is the local disease burden, what is the future unmet needs in the next 10 years. So this is about horizon scanning. Well, the other part is about HTA. So HTA, we're going to use so-called next generation HTA using real-world data to develop our decision analytical models and forecasting models to understand the future 10 years disease burden. And if we introduced these innovative medicines, what are their cost-effective manner, and what is the budget impact to our local system. So under SCAN, we're going to answer a few questions. What are the available innovative medicine in the global pipeline, and how we can prepare the local system better to this innovation adoption, and how to prepare the local decision makers and guide them to know, interpret the data. Yes, so SCAN only focused on 3 therapeutic areas as the proof of a concept study. So we focus on depression, inflammatory bowel disease, and prostate cancer. These selected therapeutic areas are the representatives of mental health burden, autoimmune disease, and oncology. So the fundamental purpose is to show how data is useful to inform decision-making. So far, in our last 2 years, we have, given the hard work of my research team and the support from collaborators from Newcastle University, we have generated this horizon scanning innovative database, which is already online from our SCAN website, so-called decision toolkits. So this summarized more than 50 innovative medicine in the global pipeline from these 3 therapeutic areas and aggregated all the evidence from clinical trials in terms of clinical efficacy, safety, and also their regulatory agency approval status. So the purpose is just an easy searchable database that multiple stakeholders can have a look and see, oh, what is readily available in the global pipeline. And on top of this, we not only publish research articles, although we already published more than 10 SAI papers, very proud for my research team. And this is, I think more importantly, is we visualized the results into our website. There are some interactive illustrations about the local disease burden, incidence, prevalence, cost of care, and unmet care needs, and the patient survival probabilities. So this is interactive illustration will allow multiple stakeholders to understand what is the current burden and what is the cost of care from the public hospital and how to fill the gap of these unmet needs. This is our international collaborative team. We not only work with department in Hong Kong U, but also work with our sister universities from CUHK, from Newcastle University in the UK, London School of Economics and Political Science, and also we work with Australia collaborators from Western Australia University. So this is our collaborative mode. We'll also work closely with local clinicians to interpret the clinical results properly. So this is us. We're not only do research articles. More importantly, we want to culture an ecosystem here in Hong Kong. So this is a collective effort from everyone. And if you're interested in real-world data outcome research, HTA, we actually have an online lectures, so-called HEOR 101. So this is the efforts from all the collaborators here. So please have a look and see how we can move this together. Yeah, so today it is our 3rd open seminar. So that is part of our deliverables as SCAN 2030 and our missions to culture local talent, to understand about HTA and bridging more dialogues among multiple stakeholders. So today we have our 3rd session on next generation HTA, and we are very pleased to have our Hong Kong Foundation, Mr. Victor Kwok, to moderate our today's panelists and the lectures. So without further ado, I'll pass the stage to Victor. Thank you, Victor, for supporting us.
Thank you, Shirley. I'm not going to speak for too long because I think today's focus should really be on the speakers. But well, good morning, everybody, and it's such a pleasure to be here. Just wanted to introduce a little bit about our Hong Kong Foundation and myself, taking the opportunity. So our Hong Kong Foundation is a public policy think tank founded by the first chief executive of Hong Kong HTA, Mr. Tung Chee Hwa, back in 2014. So we just celebrated our 10th year anniversary last year. So basically, we are a advisor and active advocate of public policy through different areas, engaging with different stakeholders, publishing research reports, and ultimately hoping to move the needle in terms of public policy, engaging with different government bureaus and etc. So the coverage is fairly broad. I think we are probably one of the more comprehensive think tanks in Hong Kong, covering obviously healthcare, technology areas, but also on land and housing, economic development, cultural, sports, tourism, areas like that as well. So I think it's one of the more comprehensive think tanks in Hong Kong. So a little bit about myself. I think some information is already there. I'm not going to just repeat that, but I think there's three main roles that I play. One is on policy research. As we mentioned, I mainly look after technology, education, youth areas at our Hong Kong Foundation. So actively advocating for policy changes in those areas. And then I think the second role relates to advocacy. So you would see us speaking on various media channels. I have my own personal columns, writing on newspapers and things like that. And then there is a third role that relates to public service, because I'm also an advisor of different government bureaus, as well as some academic institutions occasionally as a guest lecturer, etc. as well. So I think that's briefly about ourselves. And I think just one more thing I wanted to mention, how are we related to today, right? Yeah, you might be wondering. I think both healthcare and technology are key areas of our research. I think in terms of technology, we are always looking for new breakthroughs in terms of Hong Kong's new economy development. And I think biotechnology or biomedical development is something that we do have a strategic advantage in terms of our both our R&D, academic capability, as well as our high quality, medical services that we have in Hong Kong that we could really leverage. So I think we did publish a few reports on biotechnology on cross-border, for example, how we can achieve better cross-border integration, data flow, as well as things like having what we call the CMPR today. It's something we are actively advocating for, refining, advancing our own medical regulatory capability, and therefore attracting more new drug development to Hong Kong, including clinical trials and etc. Healthcare and aging society obviously is something we deeply care about as well, and as well as healthcare financing. How do we make the entire medical system more sustainable? But I think that's enough as an introduction. I think, well, we have two key speakers today, so allow me to introduce a little bit about them. Professor Manuel Espinoza is Associate Professor of the Division of Health Economics, Policy and Management at the School of Public Health at Hong Kong U. So before joining Hong Kong U, he was an Associate Professor at the School of Public Health, Pontificia Universidad Católica de Chile. Forgive me for that Spanish, but during the last 15 years, Professor Espinoza has focused his academic work on the field of health technology assessment and health economics, particularly in economic evaluation and priority setting in health. So his focus is research focuses on new methods in exploring heterogeneity and equity in economic evaluation, developing value frameworks for health decision-making, policy analysis, and applied economic evaluation. And he has also been a consultant at the World Bank, Inter-American Development Bank, the UN Office of Project Services, and the Center of Global Development. So through these work, he contributed to the elaboration and update of health benefit plans in Argentina, Honduras, Dominica Republic, Chile, public policy analysis in Belize and Chile, and implementing strategic purchasing for high-cost technologies in Mexico and Chile. So he also has different scientific societies in different roles as well. So our second speaker, Tina, is the Associate Director of the HTA Program and Strategic Partnerships at the Center for Innovation in Regulatory Science. So Tina leads CRS work on HTA strategy and research as part of the organization's mission to advance regulatory and HTA policies and processes worldwide. Her responsibilities span the full spectrum of HTA-related activities, from the conceptual development through to project execution and delivery. And she is responsible for shaping the HTA research strategy, ensuring alignment with the broader regulatory and HTA vision of the organization, and leads global strategic partnerships with multiple stakeholders to support evidence-based HTA policy development. So, and before CIRS, she worked as a research scientist at MedPharm and GSK. So I think that's enough about, just as an introduction, and I don't want to hold the stage for too long, so I'm just going to pass the time to Manuel, our first keynote speaker. Welcome.
Thank you very much, Victor, and I'm very honored of being here, and I would like to express my deep gratitude to all of you today. We're here, especially Professor Shirley Lee, who's been extremely supportive of my since my arrival to Hong Kong 7 months ago. So today, the invitation was to talk about this, from philosophy to practice, examining the meaning of value in health technology assessment. And yeah, as Victor mentioned, I've been an academic my whole life, teaching doing clinical work and teaching medical students, but then moving to public health and health economics, especially in the last 15 years. But I've also done quite a lot of work as a consultant for private organizations and governmental organizations, especially across the region of Latin America. The outline of this presentation is the same one that has been published in the flyer that announced this seminar, so I'm not gonna spend time on this. I'm going straight to the kind of a basic question of this talk is, what is value? In particular, the value of things, value of goods. And if you go to any dictionary, you're gonna find some definition very close to this one, is the importance or worth of something for someone. And goods actually are appreciated because of the benefit they produce. And if you go to the literature, in particular in the field that we work, you might realize that in many cases, value is considered equal to benefit. However, from a theoretical point of view, I must argue that this is not correct. Instead, we can say that value is a function of benefit. It's driven by benefit, but not necessarily benefit. Now, we can make assumptions that the function is the identity function, and we can just simplify the thing, saying that it's the benefit. But I'm going to argue in the next slide that it's not necessarily equal to benefit. And let me give you an example here. Think about two technologies, technology A and B. For technology A cures a disease A. Otherwise, the patient dies. Technology B cures disease B, another disease. Otherwise, the patient dies. This is a description of the expected benefits. So these are the expected consequences of having access to A or B. Now, if I invite you to make a choice between these two alternatives, you're going to have a problem. You're going to say, well, but it depends on so many factors. Here is where economists use a toy, use an instrument called the ceteris paribus. Ceteris paribus says that, well, everything else is going to be equal between these two alternatives, right? So if you think that, who are the people affected by A and B? Well, they're equal, in every sense. So if this is the case, just to simplify the exercise, what we would expect as a response is that you are indifferent between A and B. Now, let's make this exercise a little bit more complex. Let's take out the ceteris paribus and let's introduce some other factor. For example, the fact that disease A affects mainly people older than 90 years old, whereas disease B affects children between 0 and 5. So what we usually find is that if you run this survey, and you put here ceteris paribus to complete the exercise, you know, the things changes a little bit, and most people prefer B over A. I'm not going into that discussion now. What I'm gonna point out here is that the determinant of this judgment is something that is not consequences. It's not what we expect, it's not the benefit, it's something different. It's something that you know in advance when you define the problem. So exactly, there are some elements, some factors that are not necessarily consequences and benefits that might change your value judgment. These two slides that I have presented is just they are just an invitation. It's a kind of a warm-up of for the next part of my presentation. So the invitation now is to have a quick look about how different people, in particular philosophers, have think about the problem of value, the concept of value of the history. Before being here, my presentation about this was pretty much Western philosophers. But then, because I'm here, of course, I need to learn a little bit about the Eastern philosophers. And this is Lao Tzu, apologies for my pronunciation, but the father of Daoism. He thought that the value of things is mainly contextual. But the value for Daoism is functional. It's functional and it's closer to simplicity as opposed to ostentation. So if we're thinking about the value of a table or whatever, so a simple table where we can, put things over, we can, sit around and eat or have a meeting or something, fit for the purpose, that is more valuable than another table, covering gold or diamonds or whatever, right? So on the opposite side, you have Confucius, which also agrees with the idea that value is contextual, but is determined by how the good contributes to virtue. And virtue, of course, is a complex concept, but it's about cultivating social harmony, including the respect to roles and rituals. So from this perspective, this table covering gold and diamonds could be eventually valuable if it fits for the purposes of a particular ritual or whatsoever. Now, if you take these two perspectives to judge how valuable one good is, we might bring this perspective into our current discussion about what is the value of health innovation. And someone could say, well, innovation is just valuable because of the health gains it's going to produce. It doesn't matter about how sophisticated is the mechanism. It doesn't matter how it contributes to knowledge and development or whatever, or other economic purposes. It's just about how much health gains are produced by this innovation. Or we could say, no, it's not just that. It's about how it contributes to knowledge, to even sophistication or development. Well, keep that in mind. I'm going to jump to this other gentleman that you might know, Mr. Adam Smith. Adam Smith, well known as the father of modern economics. When Smith talked about value and value of the things, he made a distinction about these very two interesting elements of value. The first one is the value of use. The value of use is the subjective perception of benefits that whatever good has. For example, this phone for me has some particular value, is the benefit that it provides to me. Whereas the value of change is related to the benefits that someone else's perceives from that particular good, expressed as how much this person is giving up in terms of their own resources to have this good in return. So in other words, it's more or less like the willingness to pay or the willingness to forgo for that person. Now, interestingly, well, Smith says, generally speaking, the higher the value of use, the higher the value of change. But there are some exceptions, and he invites to review what he called the paradox between water and diamonds that you might have heard of. So he says, you know what? Why? Water is really, really useful. I mean, the value of use of water is so important for our lives compared to diamonds, really. But there are always some exceptions that people think the opposite. But generally speaking, is that the situation. But for some reason, we're not willing to pay a lot for water compared to diamonds. And the answer of Smith to this paradox is he thinks that the value of change is explained by the amount of work needed to produce the good. So because it's much harder to get diamonds than water. So that is why the value of change is higher. Interestingly, this other person that I'm going to introduce now, Karl Marx, which can be seen as in the opposite side of the road as Smith, who is kind of the father of liberal economics thought, whereas, you know, Marx is rather in the opposite side. They, though, agreed in this idea that value is explained by the amount of work needed to produce the good. Actually, Marx goes even beyond that. There is no value of use, says Marx. Value is not determined by any subjective judgment, Marx says. All value is determined by work. All value is produced by workers, and this is a foundational concept of Marx theory. Actually, Marx's labor theory of value is a cornerstone of his critique to capitalism. He says that capitalists capture part of the value, and all the value belongs to the workers that produce the products. And the capitalist takes part of the value. And you know the rest of the story. I'm not going into that part of the story. But interestingly, these two gentlemen, they share and they have the same approach to the problem of value, that value should be something that we can measure objectively as, at this point in time, as how much effort we need to put to create that good or create that product. Now, parallelly in the history, we have, in contrast to the Marx view at the end of the 19th century, these gentlemen here, Jevons, Menger, Marshall, and Walras, that are the main exponents of the marginalist school. And they propose something very different to what Marx was saying. They say value is not an intrinsic property of goods by any means. Actually, value is a subjective property. It depends on people's judgments about how much the good satisfies their preferences or their needs. And so, but let's come back to the paradox of water and diamonds. So how we explain the paradox if we are coming back to the idea that value is just subjective. So, and they introduce one new concept at that time, which we now know very well. Is this concept of the marginal utility, right? So marginal utility refers to the additional benefits obtained by consuming an additional unit of the good, measured as wellness or satisfaction or whatever you want. Now, they say the value really is explained by the marginal utility. That's why, because water is abundant, so therefore its marginal utility is low. So the value of the last bottle of water is very low compared to the last diamond, because, you know, diamond is more scarce. So now they reconcile the idea of the marginal utility to understand value by a subjective manner with a paradox that formerly Smith explained with the value of how much effort you had to put to produce the good, sorry. So what happens now? What is the discussion now? I'm bringing these ideas that Mariana Mazzucato, this Italian economist, that you might agree with Mariana Mazzucato or not, that's not the point, but in that book, The Value of Everything, there is some interesting section where she talks about the value of innovation. And there are some interesting ideas here that I want to share with you. First, today, we kind of understand that the value relates with benefits produced and not with the production cost. It's not related to the effort as Marx or Adam Smith said centuries ago. It's related to the benefits, right? But she also says that there is a risk of a superlative value, or use, sorry, of the concept of value to justify high prices. You might agree or not, but it's interesting to discuss this. So you can say why this is so expensive, why the price is so high? And someone can say because of the value. Right, so okay, because of the value. And then the question is, well, you know, if we keep value of health innovation as a subjective, non-defined notion, well, that has an advantage, which is that captures what is important for each person, recognizing individual judgments. But from the perspective of a health system, from the perspective of a normative body that needs to allocate resources, you make the task very difficult because they need to inform resource allocations and priority settings. So probably what we now need is something different, is we are going to be focused on the concept of value in an objective way, but anchored on the idea of benefit measured in an objective way. And this is where probably we are now at this point in history. And actually, health technology assessment is the process to characterize the value of a technology to inform decisions to improve efficiency, equity, and quality in health systems. And this is where we are now. Now, let's jump now to the question of, well, how we're going to understand value in health. And if you go to doctors, well, the first things that emerge from a doctor is that the value of a new health technology or intervention relates to the effectiveness, efficacy/effectiveness, the safety, probably how easy it is the administration of this new technology, and of course, innovation at a certain extent, innovation not related to the health gains the innovation produces, but innovation by itself is also something valuable for clinicians. I mean, in a first round of interviews. Then patients and families also interested in effectiveness, safety, and all that, but they also mention about the importance of how is the impact on the financial protection or financial risk of their families. They also look for the social consequences of them and their families. If you jump to health planners, managers in the health system, they are interested in the previous one, but they're also interested in the financial sustainability of the system, in a certain point, the justice in resource allocation, among other elements. And if you go to the society in general, you might find other attributes of value, such as the capacity to maintain or improve labor productivity, or the capacity to improve social wellness beyond health, right? So you might think that this is a huge task, how to define objectively value. And you might feel that, okay, there are many challenges in this value characterization. How we can build this value framework, what attributes should be used to characterize value, how we can measure those attributes, what is the process to characterize value, because different processes, you can end up with different quantities of values, and other social preferences that should be formally included. So for example, we are gonna introduce any social preference about who is more important in the society, like children versus old people, or all of them value the same for the society. This is a deep discussion. And well, this can be very complex. And you can say, you know what, we're not going into that direction. It might be better just stay where we are, and we can try to make some progress, not too much. Well, I would argue that this does not need to be too complex. And maybe the good recommendation is to start simple, but be willing to add complexity progressively. Now, willingness means start discussing today how to characterize value, to make sure what is the north, where we have to go, and what simplifications we're going to do now, and what improvements we're going to implement later on. Now, where is Hong Kong, and what next step can be implemented? So my understanding, and this is just, I'm throwing some ideas for the discussion here because you know better Hong Kong than me, but my perception is that Hong Kong has a lot of capacities for making a good clinical evidence assessment. So I don't think this is a very important problem. Maybe we need to organize better the processes and so forth, but this is not a huge problem. Now, informing decisions using cost effectiveness analysis, my perception is this is the next challenge right now. And what we need, which I observe we don't have in Hong Kong, first, methodological guidelines, because there are methods for economic evaluation, but we can adopt different manners, different approaches for many situations, and it's good to have a guidance that aligns the practices, the methodological practices. This is one thing. The second one is that we really need to have access to real cost of the system. If we want evidence useful for informing decisions about resource allocation in the healthcare system, we need data about real costs. They are not lists of prices or lists of co-payments of the population. No, we really need the cost. To inform resource allocation, we need the cost of the system. We need some time to produce good quality cost effectiveness assessments. Even in the jurisdictions with huge human capacities, fantastic computers and everything, a cost effectiveness study of good quality cannot be done in 15 days or 3 weeks. You need some time to do that. And finally, and probably the most important thing, is we need to be clear about how to use this evidence. In many jurisdictions, my own experience working in other countries is that sometimes they use cost effectiveness as a recipe just to say this must be adopted or rejected, without really understanding what is behind of the framework of cost effectiveness. And I'm going to use the last time that I have here to focus a little bit more about on the main fundamentals of cost effectiveness analysis and what the meaning of it. So this is, for all of you who are not familiar with, is the classical decision rules that everyone understand, that everyone learn when they study cost effectiveness analysis. What you've got here, is this a pointer? No. Well, there you have to the left of the equation something called the incremental cost effectiveness ratio. Incremental cost effectiveness ratio, in the numerator, you've got the incremental cost, so how much the system has to pay from changing from the standard technology to the new technology over a time horizon that is reasonable for that decision problem, expressed usually as expected value in 1 person. The denominator, you have the incremental benefit, usually in the cost effectiveness framework, expressed as a unit of health, mostly as a quality adjusted life here. It could be another one, but it's health, right? So the incremental cost effectiveness ratio is how much money the system has to pay to move from the standard to the new one for getting 1 additional unit of health. And what you have to the right, you have something that we call the cost effectiveness threshold. And that is a measure of the marginal productivity of the healthcare system. So how much money we need to put in the health system for that health system with that production function that operates today to produce 1 additional amount of health. So I'm gonna now give you a brief demonstration that cost effectiveness is not a comparison between costs and effects, of course, costs and benefits, is a comparison between benefits and benefits. So basically, if you make this very simple rearrangement, what you have here is the health gain that you expect if you move from the standard to the new technology, right? When you adopt the new technology. What you have in the left side of the equation is the incremental cost, how much money you need to pay for changing from the standard to the new. That is money. And what you have in the denominator here is the threshold, which is an expression of the marginal productivity of the health system, which is how much money you need to put to the system to produce 1 extra amount of health. So these monies cancel out, and what you have here is QALYs. So basically, if the QALYs that you expect to gain from the new technology is higher than the QALYs that you expect if you put that incremental cost elsewhere in the healthcare system, so the new technology is cost effective. So this is the health gain if the money is allocated to the health system and to resolve, the waiting list and all things that we know, right? So just to be clear, so this is those benefits that you expect in those patients that are going to have access to the new technology. And this one are what we call the opportunity cost of an alternative allocation of the limited resources into the system, which is going to produce health benefits in those patients that are waiting for surgeries, consultations, or whatever, right? So it is very important, the threshold. And it is very important to understand that the threshold is a measurement of the marginal productivity of the system. It's there's nothing about any willingness to pay. That is just a label that we mentioned, like a willingness, but it's not a willingness. It's not a social willingness. It's not an opinion of how I think the system should pay. No, it's an element of fact that is determined by the production function of the system and how money you are allocated to the system. It's just that. So people say it's the willingness to pay threshold, but that is just a name. What really is a measurement of the marginal productivity, or if you are an economist, it's the shadow price of the budget constraint health, right? So what about the threshold? Let me just finish with this idea. Let's assume that we need to do a priority setting between these 10 new technologies for which we have very good cost effectiveness analysis for each of one. And each of these technologies, let's say technology A, you have an incremental cost, which means that if you pay for A compared to the standard, it's going to cost you $20,000 compared to the standard, more dollars than the standard, and the incremental quality is going to be 0.7, right? And so forth, right? Now, what we can do for priority setting purposes is to apply this very simple rule of the league table, calculating something that we call the incremental net health benefits using that expression above, right? So what you have first is the how much health you gain minus how much health you are giving up because of the alternative allocation of resources. So the threshold is actually very important to quantify the health forgone. Now, what happens if we don't have a threshold here? We don't have any estimate of the willingness to pay, no, the marginal productivity of the system. Well, okay, pick a number. Now we have some evidence across the globe where we can identify which is the best number to fit the purpose, for example, for Hong Kong. Let's assume that for 1 minute, the threshold is going to be 1 GDP. And I'm going to estimate the incremental net health benefit. As you easily realize, if the number is positive, it's because the incremental benefits are higher than the incremental, the health forgone, right? So for all these numbers that are positive, you can conclude that those strategies are cost effective. The other ones are not cost effective, but remember, they are all effective. They all produce health. So if you have an exogenous budget to this exercise, you can just follow the ranking that I present there. So if you have money, you can say, okay, the first one that I'm gonna cover is strategy number 1, the second, 2, 3, 4, and 5. You might even be willing to pay for something that is not cost effective, but you have to be consistent that the first non-cost effective strategy is the one with the highest net health benefits anyway, right? Now, what happens if we change the threshold? Instead of 1 GDP, we use 3 GDP. Well, look, the numbers change. So all technologies now appears to be cost effective. Of course, because the threshold now is higher, right? If the threshold is higher, it's very easy that the health forgone is lower. And of course, the numbers are going to be positive. It's simple mathematics, right? So now all the things are going to be cost effective. Now, but what happened with the ranking? Well, the ranking also changes, of course, because the threshold is down there in the denominator of the expression. So yeah, it is important, the number of the threshold, for sure it is. But if you don't have it, which is the situation now, what is the second best? Well, use the number that is the best proxy based on the bunch of literature we have today, and be consistent with that number and the decision. So the worst thing you can do is, for example, saying that for those first 5 technologies, we're going to use 1 GDP, and for the other ones, 3 GDP. No, that doesn't make sense, right? So at least be consistent with one number, even though you don't like it, but be consistent, because otherwise you're not being consistent with the entire framework. Right, so let's move to the very first ones. Well, very last ones. So why is urgent to start characterizing value? Why is urgent to start this? Because the pharmaceutical pipeline, just pharmaceuticals, but not talking about medical devices and other technologies, is huge. It's around 22,000 more products are in the pipeline, and behind of that is around 6,000 companies. So if you simple math, it's around 3-4 products for each company. So the amount of risk in capital investment is huge for each one. So most likely the next 10 years or 15 years is new technologies, hugely expensive. That is the situation. And the systems are not going to have the capacity to pay for them all. Just in 2024, you know, the major part of that were oncological technologies, then neurology. Only in 2024, we had approved 174 new technologies in some part of the world, which eventually we might want in our system. And the type of molecules are oncological and gene therapies. So what is going to happen in the next 10 years is more and more innovation at really high cost prices. So what we're going to do with that to make a healthy healthcare system, but also a health innovation industry, which is going to be pushing for new technologies, but the system are not going to pay for all those technologies. So it's not going to be healthy either for industry. So if you have monopsonic power in your system and a large demand, let's say mainland China, well, you know, you can do some negotiation, that's going to be fine. But if you are a jurisdiction like Hong Kong with 7 million people, that is going to be more complex. So this negotiation, as we think about negotiation, is not possible if you don't have enough monopsonic power or you have limited demand. And at the same time, like Hong Kong, you want to create a good environment for attracting industry of biotechnology to invest in research and innovation. So negotiation, probably classical negotiation, is not the way forward. Instead, we can think about something that we can call value-based negotiation, a little bit more sophisticated, and value-based purchasing. And for that, the first thing we need is to understand what value means. So these are the final remarks. So all health systems worldwide face the challenge of financial sustainability because the significant development of new technologies. Look what is going on now in the US, that Trump is trying to put prices down. Not gonna go into that details, but even in the US, right? The potential complexity of the value characterization could be seen as a barrier for this, but should not be a barrier to start doing it. Start simple and be willing to add complexity progressively. Now, simplicity means maybe we can simplify processes, we can simplify methodological approach, but we shouldn't simplify our understanding of what is the theory behind of that. Understanding the theory behind of what we need to do so we can make good decisions about what we're gonna simplify in our process, in our methods, and in our decision-making heuristics or processes. That's all. Thank you very, very much for your attention.
Are there any questions for Manuel? I think we have about maybe 10 minutes before. Yeah, please, Alpha. Yeah.
I didn't know that.
Thank you, Professor. Thank you, Victor. Nice to meet you again. Thank you, Professor Manuel. So when we, this is Alpha from AstraZeneca. So when we talk about the value of healthcare, and then the first word that comes into my mind is demand. And in healthcare, this topic is in particularly complex because healthcare itself is a derived demand. Well, I don't want medical device, I don't want pills, but I simply want health. So, Professor, from your perspective, can any kind of HTA economic evaluations or cost effectiveness somehow, I can't say solve, but advance something that we can tackle the problem of the derived demand?
Right. So you mentioned first demand for health is conceptually different to demand for healthcare, right? So the two different concepts. So the demand for health relates to the concept of need, let's say, right? So if we have a particular notion of what health is. So whatever distance we have in all our population to that notion of health is going to be a demand for health. It's a need to restore that amount of health. That is one element, and that could be estimated through a burden of disease, to metrics that we have, right? Generally speaking, using epidemiological estimates, that is the demand for health, right? Now, if we are jumping to healthcare, that depends. The demand for healthcare first depends on the capacity of healthcare to offer some solutions to those demands for health. So there are some conditions that, as a healthcare, we cannot do anything, right? Because we don't have the technology yet or whatever. That is the main distinction between the both elements. But we can still have an estimate of the demand for healthcare if we know exactly what our healthcare system is doing, is offering, and what are the gaps in the next few years in terms of technology, in terms of services, procedures, and so forth. So we can have estimates of how much is the demand for healthcare today, how much services we should produce, how much is the gap that we need to cover in the next few years, because it's all these technologies and services we are not delivering. And we can estimate, all those estimates can be done. Yeah. Do I answer your question? Thank you very much.
All right, any other questions from the floor? All right, okay, yeah, one more, please.
Thanks, Professor. This is Jackie from MSD. So thank you for the great sharing. So one of my questions is about, so cost-effective analysis is one of the things you mentioned, right? So in terms of the value in cost-effective analysis, is there any difference between other analysis? So I reckon there are many different analyses for like HTA, right? So would there be a different set of value for cost-effective analysis and other kind of analysis?
A great question. Absolutely, yes. So HTA is kind of the big umbrella to characterize value, right? Now, one important piece of that, I think that, we can share what you think, but is cost-effectiveness analysis. Now, cost-effectiveness analysis, the main powerful element of cost-effectiveness analysis is the concept that is a comparison between benefits gained and benefits forgone, right? That is the main element. Now, some simplifications are that in classical cost-effectiveness analysis, the benefit is just health. A measure of health such as the quality adjusted life year. It's not that function that I was speaking at the very beginning. It's just health. It's a measure of quality, right? But quality is gained and quality is forgone. That is the main point. Now, you can put more things to the value in the gain side, but also you need to put and to take into consideration these other elements of value in the opportunity cost side. So that is probably the most important conceptual element that cost effectiveness gives to HTA, is that idea that always for decision making, you need to take into consideration the opportunity cost of that resource allocation problem, right? Then we can discuss what is going to be the benefit, whether health, whether quality, whether dully averted, whether it's something more fancy or happiness or whatever. That is another thing. But the comparison between gain, health, and benefits gained, benefits forgone is probably the most substantial contribution to cost effectiveness to the HTA framework. What other things we can do? Yeah, there are cost-benefit analysis, cost-consequence analysis, other things. They don't provide, I would say, a strong concept behind of the framework, such as cost effectiveness to the resource allocation problem in healthcare. And it's a whole discussion there, but yeah, that would be my take-home message.
All right, one more.
Thank you, Professor Manuel. Jun Qiao from Roche.
Yes.
You mentioned about a concept of the cost-effective threshold is the inverse marginal productivity of healthcare systems. Conceptually, I totally understand that. I want to understand practically, how do we measure the productivity of the healthcare system?
Okay.
Yeah.
Well, this is very interesting. I mean, it's going on a very huge discussion right now in the UK, for example. You can have a look at that. In simple, is a measurement of, let's think about, I'm going to present it in a very simple way. So let's say you put this amount of money, you allocate this amount of money to the system this year, and you increase in this amount next year. So you have an increment between one period and the next period. So the question is, how much health you expect to generate because of that incremental amount in the budget, right? Now, the threshold is at the margin. So if you put $1 extra or $1 extra penny to the system, how much health do you expect that the system is going to produce? In other words, is the marginal productivity. If you feel that, I'm going to show you, you remember the production functions, this. So at the point of the budget, this is just the first derivative of that at that point, right? It's the marginal effect. Well, yeah, in principle, yes. But the UK did it more than 10 years ago, and now has published with data from over 16 years data. And based on that estimate, they have produced also estimate for many countries, many jurisdictions across the globe. With, of course, always there are certain assumptions, but many other countries and jurisdictions have produced their own estimates. As long as you have data about how much is the money that is, coming to the system, how much are those increments, and how much is the production function of your system, you can do. You don't need to draw the whole production function across, 20 years. At least you need 2 periods. You need that bit of the curve of the production function between, 2024 and 2025. And that is enough because you're looking for the productivity at the margin. Okay, I can send you a bunch of literature about the methods. There are some problems, econometric problems about indigeneity and all the things that statisticians and econometricians love. But, after 10 or 15 years of methodological development, I think that is something that we can deal with.
Right. Okay, one more from Sabrina, please.
Yeah.
I would like to ask, because you mentioned about value and talking about health technology assessment. I just thinking about the health technology assessment define the benefit, to calculate the benefits cost for individuals or the entire society. What will be the differences if take into consideration of these 2 aspects?
That's a great question, and it's part of the value framework we need to produce. Now, if you take the toolbox of cost effectiveness, for example, usually we're talking about individuals. So we usually express a nicer or an incremental net health benefit at individual level, like an average at individual level, right? And then we can multiply it by the population, and we can have some, estimate about what would be the total health production at population level if you change your technology from the standard to the new one. We can do that quite easily over a particular lifetime horizon. Clinical evidence is also focused on individuals, right? But you can do some extrapolation about if you change and you adopt this new technology, what are the health gains in different metrics like clinical metrics or QALYs or DALY averted or whatever at population level. I think I don't think that is a major complication, to be honest. We can talk more about that, but it's very easy to produce these 2 numbers. The main point is if you are running priority setting, you need to express all of them in the same metric to make it comparable. That would be my main.
I ask these questions because there are a lot of debate whether we should pay for example, rare disease patients for individuals,
Okay. Right.
or we would like to pay for a better universal service coverage.
Right.
So this is always a debate. Will it be very different? Will it be some different considerations into how technology assessment in the social context or in the social values perspective?
Okay. Now I understand where you're going. I don't think there's a problem for the individual versus population. I think that is a point about what is the value of a particular technology that solve the response to particular needs of some particular subpopulation, and how much value we put that. So the other way to do this is saying, okay, the amount of health that we gain as a consequence of introducing a new therapy for a rare disease, let's say, is going to be weighted by some amount that is going to capture that social value that we consider is important, because any reasons, because these patients have been postponed, because of, there are any other, a lot of arguments we can use for that. But it's about how much the benefit captures that particular concern.
All right, I think we will have more time to discuss these topics.
Sure.
I have many questions on my own, but I think I'll save it for the panel. And I promise during the panel discussion later, I'm going to save some time for more floor questions as well. So, but thank you, Professor Manuel. And let's invite our next speaker, Dr. Tina.
Okay, great. Morning, everyone. It's great to be here, coming to beautiful Hong Kong. Thank you so much for the invitation, Dr. Professor Lee, and also the research team at Hong Kong University. So it's really excellent to hear Manuel's presentation about the concept of value and how it evolves and how it perhaps could be applied, which is a fundamental cornerstone for healthcare decision-making. So what I would like to do perhaps is to spin that from a different perspective, thinking about process and approach from the international HTA system and the insights of the policy changes, so that it's providing kind of like food for thought for discussion later at the panel, what might be the learnings and consideration for Hong Kong. So if I can press here, or maybe just, does that work this way? Oh, great, thank you so much. So you already heard about me at the introduction, but I thought I'd just say a few words about my organization. So I work for CRS, which is a global think tank. We act like an independent body that bring global regulatory agencies, HTA agencies, pharmaceutical companies, patient groups, and academic together through our safe harbor discussions to advance healthcare policy. So I'm not an economist, so if you have any hard questions later at panel, please go to Manuel. But for me, I'm really talking about policy discussions, really is what are the considerations from an ecosystem that all the stakeholders should think about. And we had the privilege as an independent body to work closely with all the stakeholders that provide us insights, their studies, their evidence. So what I'm showing you today is really built on all of the information, evidence, and research that is supported by our stakeholders. So I will first start from the change and evolution from HTA agency perspective. And then I will turn to the company thinking, what has been the mindset change and evolution from company perspective? And then perhaps broaden that to wider stakeholder to think about what we should consider when we talk about an ecosystem for the next generation of HTA. So let's start from a simple map of a patient journey to access new medicines. Very simplified procedures. You're probably very familiar with that. For new medicine to be accessed by patient, you have to go through clinical trials approved by the local jurisdiction regulator to ensure that the medicines benefit overweight the risk. Then there's a discussion of access. It's how much we're going to pay for that, it's pricing, and who is going to cover that, which is reimbursement. And really anchored to what we also talk about is a value. So HTA has now emerged as a policy to decide what is the value of the interventions so that to address the payers and healthcare systems question of market access. But if we look at the application of HTA in healthcare system, it's actually multidimensional, it's very complex. It can differ from a different scope. So HTA can be utilized to look at the value of medicines, medical devices, diagnostic tests, and more recently, digital healthcare tools like apps. And when HTA is implemented in healthcare systems as a decision-making, it can also be appeared from different format. It could be formal HTA agencies. You'll probably be familiar with the UK NICE, Australia PBAC. It could also act as a committee or a unit, a function within an organization. An example I can give is Italy, the agency IFA. So they have the regulatory function and also the HTA function sit within one organization, but they operate separately. It could also be around the academic research or perhaps research organizations that utilize HTA methodologies and principles to support the value discussions. So it can emerge in a different format. And the application could be wider from not only the pricing reimbursement, but clinical guidance, public procurement, et cetera, And it could also be applied as a single technology, which will look at one technology assessment, or perhaps multi-HTA, which look at a cluster of healthcare interventions, and we're looking at how do they compare to each other. So very complex. But for this session, what I would like to narrow down is looking at a single technology for pharmaceutical product. Think about the medicines, the innovative product, when it goes to healthcare systems. What are the current changes and the trend globally? So when I started working at the organization about 15 years ago, it was a time that HTA agency emerged and really matured and evolved in many jurisdictions. So we started from a benchmarking project, looking at different methodology, criteria used by HTA agencies. But we also realized that it's very different across different HTA agencies, just from the organizational point of view. So it could be that how it was structured and set up as an institute. What is a different mandate? Because certain HTA agencies, they probably only look at outpatient or inpatient use. If they don't look at all product, then the structure of the committee, how they met, a different composition of committee, a frequency of meeting are different, and the operation standard, how they engage stakeholder are different. So very different element can be looked at. And we know that other organizations are also looking at HTA organizations, such as WHO framework. And I know that the Professor Lee's research team had an update and recent research around how HTA agencies are different and compare across jurisdictions. So the key message is HTA are different in terms of method and criteria, but also it's shaped by how it fits into the healthcare systems, the political structures, the financial models, and history of how it evolved. So when I started working around the HTA area, there's a famous quote, I put it here, it's a bit outdated, so 20 years ago. It says that if you see one HTA agency, you see one HTA agency, because it's like comparing apple and oranges, they're so different. But what I would like to show today is actually there's a shift in the mindset when we think about how different HTA systems are compared globally. And what I have observed is actually, despite the different settings and involvement of HTA, there's actually more alignment and cross-learnings across HTA agencies globally. And here are the main drivers, which is globalizations of innovative pharmaceuticals, which we see from the previous presentation, the pipeline emerged over the years for the new technologies, the ATMPs, the oncology medicines, really enforce the need for timely access to this product, which in turn, that actually leads to higher pressure for the payers to think about how can they cover all these expensive and new technologies. there's a growing emphasis on the transparent and consistent process to decide, utilize HTA for the reimbursement recommendations. So Manuel mentioned the consistency early in the process, very important. And also, how can we perhaps think about meaningful patient engagement to ensure that the decision that's made by the decision makers is actually driving the value for the patient perspective. We also see expansion of collaboration of HTA at a different platform, professional community like HTAI, eSport, and also we see more collaborations between HTA agencies, which I will elaborate later. So all of the factors is actually the enablers for the discussion today. What is the next generation for HTA? It's not that HTA agencies are evolving independently, but more around how can we collaborate and share good practice and mutual learnings. So if we put into practice terms, I would like to start with the overview of new medicines. What is their journey to reach the patient? And this is a timeline analysis looking at new active substance or innovative product. The timeline for them to submit to the regulatory agencies, and you can see the country name listed here, and then receive a regulatory approval. So the blue bar represents the time in median for the cluster of product. In the bracket, you can see the sample size. So that's how long the regulatory agencies look at the product. So after approval, then it goes to the HTA. So these are the countries. The HTA is one of the fundamental decision maker in the process to make recommendations for pricing and reimbursement. So the product has to go through HTA review, and that's the orange bar showing that one company submitted to the HTA agency and when they received the first recommendation. So it could be recommended to reimburse or maybe not, but that just show you how long it takes in median times. So it's very interesting that you probably see the divergent picture here. Therefore, if you're a patient in an audience, you see what is the factors that influence my time to have access to medicines. That actually is multifactorial. First is how long does a regulatory agency approve? And we actually observed a very different approach. The regulators are taking, for example, more priority review processes, fast track processes to expedite the process, and also more reliance models across regulatory agency for collaboration. That's not the focus today, but we do see a lot of involvement in that area to kind of like make the process more efficient. But back to the HTA, you can see that actually different agencies are very different in terms of timing, which can actually reflect and kind of tell you the story, what is the context behind the timeline. So for example, Australia, we can see it's relatively short, around 120 days. That's relevant to the frequency and duration of the committee meeting. So every 3 months, you do the committee meeting. So you fit in the timeline, you got your outcome. Doesn't mean it's positive. If it's negative, then you go through the recycle of resubmission and reshift your submission evidence, but that shows the consistency of the process. And then the UK, England, the nice time, it looks long, but it's actually how the process was set up, because that involved a nice draft recommendation, which after the patient organizations, the public has the opportunity to comment, then there will be the next step of final appraisal or recommendation. So it's actually a different component built into the process. So another element here is also very important and normally got forgotten is the red arrow pointed out, which is what happens after the regulatory approvals. And then before that to submit to HTA agency, that's really driven by the company submission strategy. And we can see here, I pointed out Germany, relatively short, and Poland, which is one of the East European countries, we observe more than 400 days for companies after they receive European centralized approvals to submit to Poland. So you can interpret this as a company's different submission strategies, the thinking about the market share, and the drive behind the decision. But ultimately, what we would like to see is where we can shift the timelines to ensure that the whole process is more efficient and effective. So let me start with HTA processes. And what we have observed is that for the HTA agencies, they look at their timeline, which is related to their local context, related to the local processes, but HTA agencies are thinking about how can we be more agile and more flexible. So this is an example in Scotland, the HTA agency SMC introduced about 5 years ago an abbreviated process. So what they're looking at is new medicines perhaps already had existing therapeutic class alternatives that are reimbursed in SMC. Then they can do a non-full submission, so abbreviated, shorter template for submissions, less modelings, less resource intensive for companies to submit, but also save time for the SMC evaluation team and the committees. So that allows not only faster time, which you can see from the chart here, that actually represent the time for decision for individual product. The standard is blue, so that's individual assessment. And then the abbreviated submission is orange. So you can see it's really on the shorter side. So that shows the efficiency gain for the abbreviated submission. But also demonstrated that how agencies can be more flexible in terms of shifting the resource to perhaps higher needs for perhaps more complex technologies and higher cost technologies, which has higher uncertainties that require the resource dedication. So similarly, a few years ago, NICE also introduced the proportionate approach, which is similar principles with their own perspective, such as a light touch fast evaluation. So this really shows that the HTA agency, they're thinking about, although I have my standard process, what can I do to make it more agile and also to make sure that my resource is allocated to where it's most needed. So not only the process, but also agencies are challenged that we need to provide access to the patient as early as possible for this medicines to address unmet need. And examples I'm giving here is a mechanism introduced in France since 2021. It's called early access pathways. So what does that entail is that it could actually provide the medicine access to patients before or after EMA approval, but before the formal HTA process start. So there's a number of criteria put in to apply for this pathway, such as this medicine need to address unmet medical need. There's no alternative therapies currently in the healthcare system, and company has to commit to real-world evidence generation plan if they go to this process. But what that enables is that the access will be provided to patient before the HTA process can start. And in 2023, we can see that actually about 50% of the products submitted by company underwent this route. So what about the time that's saved? So that can be seen from the chart on the right-hand side. So if you look at the top, the ones go through the early access pathways. The blue bar shows the time for EMA to approve the process. And then the green bar means that after the EMA approval, how long the HTA agency will decide, okay, you can go for the early access. So only 2 months. So it means that after 2 months, the patient can access the new medicines. But it's a temporary pathway. It doesn't mean that the product will bypass HTA process. The company still need to look into their dossier submissions and submit it to HTA for a full review, which is the orange bar later, that after early access, that still goes through the HTA process. However, if you compare to the bottom, which is the standard pathways, you can see that there's a significant time saved for the patients to have early access of the medicines. So it's, again, a flexible thinking in terms of how I can provide medicines to patients when it's really high unmet need. So we talk about the process. What about the outcome? So what I would like to show is the UK as an example that use managed access and dedicated funding, for example, the Cancer Drug Fund, to provide the access to medicines when there's uncertainties in the clinical evidence. So the Cancer Drug Fund is dedicated for funding medicines which through the NICE standard appraisal to deem not cost effective. So if a drug is assessed by NICE and realize it's not cost effective, beyond the threshold, that could go through the managed access with the specific funding mechanism of Cancer Drug Fund. However, for the product to go through this process, of course, they need to sign an agreement, which is a couple of years commitment to continue collect data while it's provided to the patient. So the companies and the NHS will work together in terms of real-world evidence plan. How can we generate the informations to continue inform the decision later on when it goes through the standard process? And here is an example that you feel free to check online that really just shows that by 2017, the product ibrutinib was submitted for indication for a rare disease oncology product. A single-arm trial, not enough information, high uncertainty, high cost-effective threshold, high cost-effective results beyond the threshold, but it was provided to patient under the particular agreement with a particular funding. And based on the experience, and recently the NICE also introduced what is called Innovative Medicine Fund, which is similar idea, but for non-oncology product. So we can see that not only the process, but also from the access point of view, there's a different thinking in terms of how can we perhaps manage the uncertainty while we can provide certain level of access in a perhaps managed way. But that required not only HTA and the company working together, but also the whole healthcare system, such as NHS, to continue provide the evidence generation post the availability of the medicines to patients. So that's a process, but HTA agency also continue to evolve their procedures as well as methodologies. Here, just example of years back, the NICE published the new method and process Australia. They went through the HTA review and in the process of implementing the recommendations. And Manuel mentioned the new threshold, which were heard around NICE this week. So that really shows that the HTA agency, regardless how matured or established you are, they are continue to think about ways to improve so that they can address the question for more expensive and innovative product. But we also see that the progress is not only done independently or in isolation with agencies, we also see more collaborations. This is an example of a working group of HTA agencies. So UK NICE, Canada, PBAC, and also ICER from the US as a research organizations. They put their heads together to think about what is the surrogate endpoint that utilized in the HTA decision-making. Can we come together to think about our challenges and our understanding of this and produce a report in terms of the guidance? Perhaps more for them to learn from each other and for internal guidance in terms of how it should be considered in submissions and HTA decision-making. So really shows that the agencies are evolving, but also collaborating in their thinking. So that actually leads to my point that if we think about, okay, it's very divergent of HTA systems, but actually there's a lot of similarities in terms of the challenges they face and more involvement in terms of how they should work together. So this is kind of like building blocks or steps of a different level of collaborations among HTA communities. Started from the bottom, standard processes, national procedures, HTA conducted their independent evaluations. We talked about earlier than the method guidance, how the different agencies come together to think about some of the methodological challenges. But we also see emerging collaboration at regional level. So one example you can see here, FINOS, they changed the name recently. This is really for the Nordic countries, so North European HTA agency together. They think about how can we actually perhaps work share. So we take turns at the different tasks of the evaluation so we can perhaps utilize each other's resource and knowledge and capacity while they make their own decision independently. There's also regional joint assessment, Benelux, which is for Belgium, Ireland, Luxembourg, and the Netherlands. So the cluster of countries, you can imagine the map on European continent, they are kind of like neighborhood, and they think there's some similarities, their healthcare system and the thinking. So they established the Benelux initiative to think about what can we do together as perhaps joint assessment, joint price negotiation, and joint procurement. So that has been evolving for the past 10 years. But what perhaps is most significant or radical changes in how HTA work together is what comes to the European level of joint clinical assessment, which started from this year. So it actually is a collaborative approach for all the HTA agencies across all 27 member states from Europe to work together. So what does that mean? So it's actually under the HTA regulation that adopted about 3 years ago, no, actually 2019, and it come to implementation from 2021. It started from this year, really to harmonize the HTA process in Europe, because there's perception that there might be administrative duplications and maybe the waste of the resource to replicate same assessment at a different member state, really to think about how can we streamline and improve the process together among national HTA bodies. So this concept evolved over decades through some of the initiatives. You might be familiar with UNITA, but then after all the pilot and the test, this has come to reality from this year. So what does that mean? Is we know that HTA healthcare system are so divergent, so we cannot harmonize European decision for the same access decisions. But what come to realization is we can look at the HTA from two domains. One is high level clinical domains that answer the question of what is the health problems? What is the current utilization of health technologies? What is the relative clinical effectiveness and safeties? So really it's just think about the new medicines to address the clinical domain. For the non-clinical domain, which is relevant to the economic evaluation, the cost-effective analysis we heard earlier, the organizational aspect, ethical aspect, social aspect, legal, really is related to the individual member states and national healthcare settings and the financial capability. So that should be left at member state level. So the clinical assessment jointly will then focus on the clinical domain without any conclusion or value judgment of what should be reimbursed or not reimbursed. So that remains a mandate for member state. However, by working collaboratively at joint assessment level, that will bring all the stakeholders together across member state to assess and perhaps harmonize the evidence requirement across member states. And as all policy changes, it's not actually being implemented overnight. So there's implementation rolling scales. And this year, starting from oncology product, and the 2028 will be orphan, and then for 2030 will be for all the medicines that will be approved and reviewed by HTA agency in the joint clinical assessment procedures. So that really showed the mindset change of how HTA are different, but also can collaborate together where it's possible. That also changed the process. So the traditional process of we got the regulatory approvals, then we go to HTA submissions, and we receive recommendation, do our pricing negotiation, reimbursement has changed. So this is a timeline under the HTA regulation for joint assessment. So you can see on the top actually shows the regulatory process, breakdown by very detailed procedures for EMA to look at the submissions and make committee decisions, the CHMP adopted the opinion, and how European Commission will authorize market authorizations. But the joint clinical assessment will now happen in parallel as the EMA procedure. So once a company submitted to EMA, they need to start the JCA processes, start from scoping with a national member state to think about what is their definition of the patient population, comparators, outcome measures, then consolidate the thinking, ask company to submit their dossiers. And you can see if we look at the endpoint, the output of the joint clinical assessment is only a number of days after the European Commission's. So very, very close and parallel process. That actually shifted not only how HTA worked at agency and system level, but also for company that traditionally, if you think about the market access team to submit dossiers after approval, now you need to work more collaboratively with your regulatory teams within the company to think how can we use the evidence to enable the process in parallel. The output of the JCA is not legally binding, but it's formed as decision-making recommendations for national agencies, and the national agency is asked if they want additional information, additional requirement, they need to justify that so they do not duplicate what's done in centralized level. So far, there are about 10 products underwent this process. We're still waiting to see what is the outcome. It's probably next year, but I think that really drive the main shift of how HTA are operated from process and also methodology perspective. So this is how the European level has changed. But since we think about how HTA and a regulatory process is interconnected, this is actually an example of certain jurisdiction where a company can submit to HTA agencies to start their HTA assessment for pricing and reimbursement assessment before they receive a regulatory approval. So this has been seen in the case of Canada and Australia, which is enabled in the system. And we measure the timeline, again, it's very familiar to you now. Regulatory time, blue, and followed by HTA. We split by the left-hand side is more, what happened more parallel. So the companies submit to the HTA before they receive the endpoint of the HTA regulatory approval versus what is a traditional sequential. So this is purely company strategy. So company can decide if they want to submit it earlier or not. However, if from timing point of view, you can see that's actually a lot of benefit to shorten the timeline to receive the first recommendations because of the parallel process. And I think the agencies themselves are very keen to encourage companies to go through the parallel process. They believe it's beneficial for the system, really to have more efficiency gain for the decision making. And I think there's an aim to actually promote more parallel submissions to more than 60%. So that's from the HTA agency perspective. We'll talk a lot about the process, more agile, more collaborative. But what about the outcome? So this is a measure we looked at last year, 2024, for the new active substance. Once they are approved by a regulator, what is the HTA recommendations? And this is simplified as three categories. The green as positive means HTA after the assessment and appraisal, I recommend for reimbursement. Orange means a certain restriction was put into place, either limited populations, the clinical aspect, or financial aspect. So there's a limitation put into, but it's still recommend for listing. While red means I do not recommend to be listed, which means the company has to resubmit, change their the modeling, perhaps collect more information to really enable a better argument at the level for HTA decision making. So you see the divergences. So what went wrong then for the ones perhaps got yellow or red? We asked our industry members, so our stakeholders, what are the issues that you faced when you submit to HTA agencies? And here is distributed by different countries. You can see that the name on the right-hand side and listed of what is the problem. And then we ranked it by what is the frequency of the issue. So the red means that this is across all the companies that responded to the study, they feel that it's actually most highly frequent, the most challenged issues, and then compared to the median frequency and the lower frequency. So different agency, different jurisdictions, they have a different picture, but we do see actually what I bolded is some common themes. The challenges are not cost-effective or unacceptable price versus comparators. So what we heard from earlier presentation is really you need to compare what is the gain of your benefit so that the comparator choice is very important. On the clinical aspect, insufficient efficacy improvement of a comparator, again, what you need to demonstrate your value proposition, and the trial may be too short and lack of long-term outcome, so it's a high uncertainty for HTA agency to make a decision to say, I would like to cover your medicine. So if you look at the issue, it's not the issue for HTA when it's submitted to agencies. This is the issue that company to consider and address during development. How do you design your clinical trial to demonstrate the value, to implement the comparators that is meaningful for the healthcare system? So therefore, if we think about company's perspective, that really required that the traditional thinking about let me worry about my market access and the pricing when it's approved and let me do my modelings and submit to HTA, well, it's too late. Because a lot of the uncertainty is actually raised from how you design your clinical trial and how you demonstrate your evidence. So therefore, when we worked with our member companies over past decades, we saw a mind shift change in terms of how we should build our clinical trial is to include HTA requirement so that the drug is not only designed for regulatory approval, but also for reimbursement. So that involves the company need to have understanding of the standard care, the reimbursement environment, what should be the correct outcome measures they should collect during the clinical development, because otherwise it's too late if you don't collect the outcome data. And then also it's a cross-functional mindset change. It's not only a HEOR or access team's problem. It involves multifunctional discussion during development to think about how can I build my value proposition. So shift the value from just assessment at the downstream to earlier upstream decision-making. How can I build my value stories in comparison to what is the standard of care or my competitors? So company can do that from a variety of mechanisms, such as their own market research. They can interview KOL talking about the previous payers or ex-payers. But one of the example I would like to show is they consider all the requirements, such as wanting to be put into development around thinking of target populations, unmet need, clinical effect, what is the endpoint. But where do they get this information? It's actually emerging from the early interactions with HTA agencies. It's so-called early scientific advice. So that has been available for about decades now in many of the HTA agencies. So the agency can provide formal advice to companies during development to tell them, what do I think about your clinical trial design? So a couple of notes, this is volunteer-based. So company will initiate the process. They will think about, oh, do I need the advice from the agencies? How can I use this as a validation for my development plan? So it's basically voluntary. And it's non-binding. So it's advice, it's not obligations. In particular, for oncology product, for example, when you take the advice and when it goes to your clinical trial and then the readout, when you submit to HTA, the landscape might change. So it's non-binding. And it's confidential, of course, and there's a firewall between agency assessors who provide you advice and the one who actually do your assessment and review later on. So this really shows that there's more interaction now between company and HTA agency at an early stage to not only think about how can we manage the access part, but also how can I shape the innovation. So the role of HTA kind of changed from gatekeeper to more perhaps an enabler for innovations. So on the bottom, I showed the process, that's a company's applications, and then the HTA will decide whether they want to take this based on their criteria. They have the meetings and output. This actually can be done at a different format. For example, company can go to agency they think is important to the market. For example, they go to England NICE. They can also go to what is available as a parallel advice that provided from both regulator and HTA at the same time. So that's possible in England, for example. The regulator, MHRA and NICE could come together and give you advice in terms of your clinical trial. Having said that, the advice will be separate. So what the regulator and HTA think will be from their own perspective, but that's an opportunity for company to understand two stakeholder needs at one meeting, and also it's an opportunity for two stakeholders to learn from each other. So what we have done is to really follow the product that is under development, and we'll ask our member companies, so what is the question you ask? What do you think is important for you to have the interaction with agencies? So this is actually based on our practical experiences of 48 meetings that has happened between company and agencies. Company can select the questions they want to address. There's a couple of components, but I would like to highlight the most sought after advice is around how do they build the efficacy effectiveness evaluation, trial designs, and also PROs. So what is the patient perspective that could be built into clinical development? So I talked about the agency change, the company change. Really what we would like to see is put it together. What is a good quality for the decision making, and really specific around the pharmaceutical product assessment for a single technology assessment. So when we talk about this with our stakeholders, this is actually a concept framework discussed at our workshop and come up with what is the content of HTA decision making that really refer to meet the expectation. So for the companies, really they think what is a quality HTA review from the agency, and for agency they think what is a quality submission from the companies so they can work in collaboratively. So from agency perspective, timeliness, efficiency is important. We saw many of the metrics that collected by CRS is show how can we perhaps build more timely assessment into the procedures. What might be the special review processes that perhaps we can consider, and how can we perhaps do more rapid of agile HTA. Credibility, robust methodologies. That's what we heard earlier. So we need consistency and robust methodology. It could be simple, but the concept should not be. And we need to address unmet need and healthcare priorities. It has to be relevant. Ultimately, what is the impact? The impact to understand HTA on actual payers and evaluating how HTA decision-making is in terms of the impact on diffuse of the technologies. So all of this come together as what we think about as from agency perspective, what are the qualities? For the company perspective, the good HTA submission started from how can we meet the HTA requirement, start from clinical trial designs, how can we incorporate the evidence requirement, how can we utilize specific measures, and how can we tell a good story to demonstrate your value proposition to different stakeholders at the different healthcare systems. So that's from the company and agency's perspective. But what's important is the end user here is a patient. So how can we ensure that what we are evolving is fit for purpose to bring value to the patient? So what I'm going to show is how can patient perspective being built into HTA decision-making. This is an example from Scotland HTA processes for ultra orphan product and end-of-life product. If the initial assessment of the product is not cost-effective, so it's likely to be not recommended, company could submit for a PACE meeting, which is involve patient and clinicians, which is an opportunity then for the committee to hear the insights from the patient and clinicians, which perhaps is not fully captured in a traditional cost-effective analysis. Really that focus on the added value from the patient, the carers, a clinician perspective, think about what's their need. And a survey by the paper listed here on the top, you can see that's a different component that the PACE meeting added to. And you can still see that despite the PACE meeting involved clinician and patient, there's also divergence between the two stakeholders consideration, in particular about opportunity for treatment choice and providing hope for future. So that's very important for the patient to address these two elements as added value for them. And our data shows that for the assessment done by SMC in the past 4 years, standard process without PACE meeting, you can see on the bottom, is about 58%, and majority of them are reimbursed and some is not reimbursed. But for the ones on the top, so 42%, if there's no PACE meeting, that means those products will not be reimbursed because they are not deemed cost effective. But because of the PACE meeting of added insights from patient and clinicians, we can see 32 products actually wasn't reimbursed after the PACE meeting. So that really shows the importance of think wider of just cost effectiveness, which capture conventional value, but also wider value from the actual end users of the patient lived experience. So we did a survey this year with global HTA agencies, so it's very fresh data. We have 17 agencies responded to our survey to ask them how are patients engaged in your processes and decision-making. So on the top is more granular around how patient engagement in relation to the assessment. 82% says actually a patient could provide formal written submissions during the assessment. They are encouraged to comment on the draft recommendation. So that's why I mentioned, for example, NICE. They have a longer procedure because they built this component into their standard decision-making. And also there's a number of HTA systems that patient advocate can be part of the committee meeting. So it's actually on the individual assessment level, there's good engagement from patient perspective. On general level, the agencies also run training sessions for patient advocate. There will be a specific disease area meetings to discuss and understand the insight from the patient. Patient be can be part of the official scientific advice I mentioned earlier, that during development, if the HTA and the company are talking about clinical development plan, patient can also be part of the advice meetings to tell them what they think is important and to be captured in the clinical trial. And finally, that patient can encourage to comment on the clinical and treatment guidelines. So that's very important. They are part of shaping what the clinical practice should be. So that shows a really good picture of actually thinking wider than just company and agency dimension. It's actually what is most important for the patient. So I'll finish my presentation with a final great example. If we think about next generation of HTA, what is the ideal ecosystem to align all the stakeholders? And here's the example from UK. It's called Innovative Licensing and Access Pathway, short name ILAP. So it's a pathway to actually accelerate development, approval, patient access for transformative medicine. So what happens is that for the ILAP, it's a procedure they claim as the end-to-end streamlined process to engage regulators, MHRA, HTA agencies, NICE, SMC, patient companies, and also the payers, NHS England, supported by research bodies and other academic bodies, which bring everybody that's relevant to the ecosystem together to think about how can we shape the process. So what does that evolve? One thing is called innovative passport. So if the company want to go through this, they believe that the product fit the criteria, they can apply for the innovative passport. So innovation passport granted their access or criteria to be part of the ILAP. Then what happened is the development of target development profile, TDP. So that is kind of like a blueprint for the product development. So all stakeholders, regulator, HTA can help shape the dynamic TDP. So that will evolve over time during clinical development through the new evidence generation, but all stakeholders can contribute to the development of TDP through, for example, early advice from both agencies, from HTA and MHRA, the regulator, and also different advice on perhaps modelings. Where do you think it fit in the access environment? So really is a supported mechanism all the way through the process to the access to England, NHS coverage. And the patient provide direct advisory functions throughout the whole government and engagement, ready to inform the evidence needs, system readiness, and design of the pathways. So really, this is kind of an innovative way to bring everybody together to enable a faster access to new medicines. So with that, I would like to summarize. We talk about next generation of HTA from policy and procedure point of view. We saw the HTA are changing. They become more agile, more flexible, perhaps what we call risk-based evaluation. They look at proportionate, they look at abbreviated, really to think about how can they allocate the resource to what is needed so that they can use also the managed access mechanism, different funding mechanism to collect real evidence to support timely decision-making. And companies, they need to think about value propositions early from development, supported by advice from agencies and patient-centered evidence generation. So we need to think about alignment of regulatory and HTA from process point of view, where we can perhaps have more efficient process in the whole system and coordinated to streamline the pathways. And finally, when we talk about the value framework, value-based decision-making, value is go deeper than just cost-effective analysis, really need to incorporate wider perspective from the patient clinicians with a structured engagement and a relevant experience data. So with that, that's my presentation. Happy to take questions.
All right, thank you. Well, with the time in mind, I'm just going to ask if there's any specific one or two questions for Tina before we move on to the panel discussion. Just maybe one or two max. Yeah. Anyone? All right, if there's not, I think we can just jump directly to the panel. And then I'm just going to invite, Professor Manuel and Tina and Sabrina, and of course, Professor Shirley Lee back on stage. And yeah, let's take a seat. Maybe I'll be on the side. Yeah, easy. No, please. Yeah, you're in the middle. Yeah. Yeah, I can just moderate. Yeah, thank you. All right. Well, thank you very much again. And I'm just going to start by saying, obviously we heard very valuable perspectives. Actually, there is a lot of connections between Manuel and Tina's work. I think because Manuel started with how we define value, right? And then Tina moved on a little bit to talk about how international agencies take that value and to actually evaluate it and to actually put that into different practices and scenarios and how we understand that. But I'm going to start back with Manuel because you gave us a very, well, let's say a very simple equation, right? How you measure cost, benefit. I think there's three components to that equation. Cost is a known factor, right? It's a dollar sign. That the threshold is something you assign, right? On what threshold you want to meet. Now benefit is, I think, is the most complicated part, right? Where do you measure it by life expectancy? Do you measure it by quality of life? It's rarely, the way it's presented makes it look like it's a quantifiable or but it's rarely linear, right? In practice, like health is rarely a linear factor. You can just 1 minus 2 and and to measure. So I do wanted to know a little bit more about your thoughts about how any for Hong Kong right now we don't have such a system, right? So we have to start from somewhere. So is there a simplistic way of understanding what we measure to start with and how we add complexities as time evolved to add more complexity to the way we understand the B1 minus B0? So yeah, please.
Thank you very much for the question. Let me start just saying that, yeah, you're right. I mean, cost is something like very empirical based. The threshold, though, I wouldn't say that is something that you assign. It's as I said, is a measurement that is an empirical measurement of what is the marginal productivity of the system. So we need to measure that, right? So as something that is there. The system is working as it is, it receives some money, so we need to go and estimate. So it's an empirical estimate. Then the benefit, you're absolutely right, is probably the most complex part. That's why I suggested first we should start discussing about what value means, because the benefit, maybe it's not benefit, it's value, really. What we want to maximize is value for our society. So the first part is to understand what we're going to consider as value and to have that reflection, deep reflection. And then once we get this deep reflection and we understand, value should contain all this, we need to start simplifying the things, because we're going to get it to a point where it's too complicated, right? There's a lot of attributes, a lot of complexities. And this is what actually in many jurisdictions happen and say, no, it's, it's so complicated that let's start simple. Let's simplify the thing as and understanding value as, health. Because the business here is we're going to provide money for the health system, and the objective of the system is to produce health.
Yeah, I think we can put the social impact aside for the time being and just focus on health. But I'm just going to throw you a very simple scenario. Let's say I have a stronger oncology drug, but with stronger side effects, right? How do you put that into the equation? Because obviously you have better health,
yeah,
but
the side effects affects health as well. So you put it in the model, and is the health gain, how much increase your survival, but also your quality of life, and you discount the decrease in quality of life because of the side effects. So it's a matter of modeling health. Still, it's health.
Right. I think that's where I put it to Shirley, because obviously Scan 2030 is an attempt to do something like that, right? So what's your approach of handling all these complexities and yeah.
I think the model itself is a mathematical equation. So we try to mimic the patient journey. through this modeling, including the clinical efficacy and safety. Safety is also being considered as part of the utility. So QALY is the aggregated outcome, including the clinical so-called benefits and also the side effect. However, our model actually is not perfect. There are a lot of uncertainties, especially when we are forecasting long-term effect. So that's why we need more complicated sensitivity analysis in terms of the building of the model itself. And then we have to communicate with the policymakers clearly about this uncertainty. So what do we mean by this different type of uncertainty analysis and how to interpret the results properly? So that's why we have SCAN, and that's why we have a HEOR 101. We make the concept as simple as possible. Each of these elements is just a 10 minutes video. So we try to use the simplest message to interpret the potential risk results that we have. Yeah, and again, cost effectiveness is only one puzzle of the whole algorithm. HTA is a big umbrella. Cost effectiveness is just one thing. We have to consider the whole value framework, including what Tina just mentioned, and meet patient needs, breakthrough therapy, innovation values, all into this consideration, not only about cost.
I think that really brings a question to Tina, right? Because what we are talking about is, how we measure or how we build the system for health tech assessment in Hong Kong. Now, one of the key of having that system is that it needs to be, well, ultimately, the purpose of doing all this is patient access, right? Ultimately, you want to bring the drug to the patient. So it needs to be quick. It needs to be a relatively simple process, right? You don't want to lengthen the process, right? Because we have all heard about, for example, in Hong Kong, we've all heard about complaints against the hospital authority, for example, that says, it's a black box. I don't know how you're approving all these drugs. Most of the drugs got rejected. We've all heard of all those complaints. Now, the problem that I have in mind is that once we put in a HTA, it means additional processes, right? It means additional bureaucracies as well, unfortunately. So is that actually going to lengthen the process? I think that really brings it to you, because you discuss ideas about, how we can, for example, the drug registration process and the HTA can happen simultaneously, and so as to save some time. So I also wanted to hear your perspective on that, on when Hong Kong tries to build its own HTA, how can we make sure that the process is not actually lengthening the time that patients actually get access to the drugs, instead of shortening it and making it more efficient and effective?
Thank you. Actually, I have 2 points. So one is corresponding to the black box, decision making. So I think what is very important, hearing from all presentation, is the transparency of the decision making. So example of the Scotland I showed earlier is, it's not necessary the clinician-patient meeting will lead to a recommendation, but because of the process there and it's transparent, patients know how decision was made, and they're happy with the rationale of the decision making. It might not be the decision they wished for, it could be rejections, but they can understand, because to think about the value-based decision making is not everything for everyone immediately, because that's not sustainable. But I think what is needed is that we have a consistent methodology, the rigorous decision making that's transparent. So for the patient, they understand how it was made. So that's more general comments. But then think about how HTA should be built in the process, so that's not lengthy. Actually, it's back to Manuel's point, is we need to think about methodology first, the guidance, so that we have something scientific to depend on. Then the process is just procedures that you can make a parallel or non-parallel. It's perhaps more administrative or procedure point of view. But I think the foundation of the science, which is value-based, is actually the key, which is enable the actual decision-making, that you can actually have the public transparency to explain to your patient and clinicians.
I have a specific follow-up question though on one of your slides, right, about the reasons why the drugs are being rejected, the one you showed. many of those actually still show, for example, actually they are still hurt, like the conclusion is still something like, for example, the drug is too expensive, or that it's not significant enough compared to the comparable, right? So it doesn't really need it doesn't really need a very sophisticated process to know that the drug is too expensive, in the sense that you know that the cost is too high from day one. So I would inquire a little bit about what do you think is the value of that entire new process being built in, or is it for when it brings it to a more practical context of for example, the NHS, even though you might have all those processes in place, but ultimately to them it may still be a cost consideration at the end of the day. So is it a genuine attempt to actually define the value of the drug and to do sort of the evidence-based kind of drug selection, or do are there some cases where it actually still becomes sort of a backward engineering from a conclusion where they just feel it's too expensive and they need a process to reject it? So you see what I'm trying to get at? What kind of how do you see it calls on the value of the HTA itself, and how do you figure out this sort of perspective?
Very tricky question, because a lot of discussion we have with stakeholders, HTA is just smoking area that to cover that is actually too expensive. So I think back to the value. So whether it's expensive is in relevant terms to the value it brings. So I think HTA is a scientific tool to tell you perhaps the judgment, but then it's actually the payer's decision for whether they can afford it. So give you an example, like Ireland. So when they go through the process, they actually have a two-step process. They can do a very quick, rapid HTA, then they decide, oh, I can reimburse, or they say, oh, it's too complex, I'm not sure I can do full HTA. Now I need to do full modeling to understand whether I can pay for that. But not all the product actually need to go to that stage of full HTAs. And there are occasions that companies just negotiate with Ministry of Health that they reduce the price and then they got reimbursed. So I think it's a payer's decision to manage that part, but HTA is a supporting tool to understand where perhaps modeling, the value judgment is needed versus perhaps a simple reduction of price is needed. So I think without the value framework, we cannot differentiate this, because think about the payer's decision. There are two types of errors. One is you recommend product you should not recommend, a waste of public resource, or you don't recommend the product that should be recommended. So how to avoid that uncertainty is really what HTA is put into place, is think about all the evidence I have at that particular decision-making point. Can I make a scientific judgment? Or is that something we need to perhaps monitor over time through real-world evidence collections, talking about managed access, really to have a kind of mechanism to devolve the uncertainty to something more certain from the real-world evidence collection point of view. That's what actually 2030 scan is really helpful, is to think about how can we perhaps shift to the decision points when there's higher uncertainty, and how can we manage that?
Thank you. I think I want to ask our next question to Sabrina, because you represent the industry, right? Which is obviously the critical part of all this equation. Now, I was reminded that I actually forgot to introduce Sabrina properly at the very beginning. So Sabrina is the Senior Executive Director of the Hong Kong Association of Pharmaceutical Industries, Hong Kong API, and obviously a member of the high-level steering committee on microbial resistance, and a member of the Business Facilitation Advisory Committee, and chair of the advisory board of the Hong Kong U Bachelor of Pharmacy program, adjunct assistant professor of CHA School of Pharmacy, and a member of the APAC Biopharmaceutical Working Group of Business Ethics. So I think you wear multiple hats, on academia, on the industry and side, you do things inside out. So I just wanted to hear a little bit about your perspective, because when we are talking about all these HTAs, one of the points Tina mentioned, for example, is how industry needs to be involved early in terms of, actually being consulted. So the industry, while developing the drug, they already need to consult the HTA committee to make sure that the drug developed is not just viable in terms of a clinical perspective, but also in terms of a commercial perspective. So how would it affect, the way the companies operate? And what do you see the value is to the portfolio of companies that you look after?
Thank you. Today is a very inspiring presentation. I learned a lot. But after the presentation, what come to my mind is Hong Kong is a very small market. So how can we bring a very cost-effective HTA in Hong Kong is also very important, because simplicity is very important, efficiency is very important, but at the same time, how can we use the evaluation, maybe HTA, maybe, but HTA could be an umbrella because it is very important what kind of attributes we put in HTA. Yeah? So with that regard, how can we use the HTA? Just like Tina, you mentioned, we can have a simple price negotiation, or HTA is helping us to do, or helping the player to do price evaluation. We can have a threshold, but we can have no threshold because it is really depends on how we use it as well. And which point we would like to use it. We use it at the very beginning when we introduce the innovative medicines, or we use it in the review process. Because when we talk about the, one of the presentation talking about we need a long-term impact, especially talking about side effect, because sometimes we do 3 phases of clinical trial. It doesn't mean that we can disclose all kinds of new indications sometimes, or the side effect, during the time. This is why we need to have pharmacovigilance afterwards. We call it phase 4 clinical trial nowadays. So it takes time, but we cannot delay the introduction of innovative medicine. So which point we do what is also very important. This is what I would like to consider when we develop our HTA. And at the same time, I do think the consensus is very important when we talk about how to bring our member companies, how to bring HTA as one of the consideration at the very beginning when they develop medicine or develop their protocol of clinical trial. Yes, it is a very good suggestions. But this is go back to the questions I asked Manuel. Innovation. Do we want to predict the outcome of innovation? Or, of course, business always we want to have some predictable outcome. But for example, rare disease, how many rare disease medicine can be profitable? And for example, like when we are when I have our meeting in antimicrobial resistance, we find that antibiotics, new development of antibiotics is not a lot. The reason is it is very difficult to convince to develop a medicine which is defined to be better not to use it, right? But we need people to do that sometimes. This is why, for example, like we work with Bill Gates Foundation, our industry globally, some charity work in order to develop some new medicine. So I just, I don't have an answer, I have to say. But when we always think about cost effectiveness. But I still recall one of the presentation last time when I hear Manuel's presentation, what, let me think a lot is how do we bring non-cost effective medicine to patients if we think about social value? So I have a lot of questions, but I don't have an answer yet. But Hong Kong, one thing is a very small place. So if we think about and also we are not poor jurisdiction, not poor market. So how can we ensure the patients have the optimum intervention when they have when they need it? I think that's something we also need to think about that.
Thank you, Sabrina. I think I want to throw it back to the other panelists. I think that there are many questions embedded in the response just now. I think one is, the threshold is something that you set, right? The cost effectiveness. So if I want to favor or if I want to reject a particular medicine, I can just change the threshold, right? It's as simple as that. So that would change the ranking, and obviously the medicine would be rejected as a result. I think another point is also that, for example, for rare diseases, you might not have a good comparable to start with. So that, that equation wouldn't work in the sense you don't have a base case to compare. So how do we tackle all those scenarios to make sure that, all these new drugs are able to be introduced based on some metrics that you might not be able to very accurately capture? So yeah, anyone who wants to comment?
Host. I'm the scan host, so I should be the first. Thank you, Victor. Actually, I'm thinking based on Tina's presentation, I'm thinking a lot. France has an early access program. So that triggered my question, what is the criteria of innovative medicine that they can qualify to be determined into this early access program? That's my question one. So this is also linked to Victor's question. Rare disease patients, they have no options. They have been waiting for so long just for a breakthrough therapy. We still go through the formal procedure of cost-effective assessment. Is that still needed? I don't think that is a need. That is a waste of resource of our research talent. That's my understanding. So I want to point this question to Tina. What is the criteria in define innovative medicine to qualify them into the early access program?
So on the website, they actually have a whole list of criteria. It should be there's no treatment available, for example, and then it should be deemed to be effective, and also to do a follow-up real-world evidence plan. So it's very, very detailed criteria in France context. Because when you talk about unmet need, again, it's different for different jurisdictions. The demographic here, unmet need might be different from Europe or Latin America. So one thing happened in Europe is through the joint clinical assessment, one element is unmet need, and then what they want to look at is what is the unmet need pan-European perspective versus individual jurisdictions. So what is the actual divergence between member states and the European unmet need definition? So for the France, it's very simplified answer is you can go to website. They have very, very detailed criteria, and they actually, when they apply, they have to be assessed whether they meet the criteria. But then think about rare disease. It's actually one of the research questions we have been doing and also question ourselves is, do we need a different process for rare disease? So Scotland do, they have ultra orphan pathways. So NICE that do not have rare disease, but they have a highly specialized pathways normally for the rare disease. And in the decision making, they would put a different modifier into the framework they're using for HTA, so that they actually can look at them from a different perspective compared to the other type of product. But I think that really draw the question, the lack of perhaps dedicated pathway for rare disease. So what we observe is just Scotland have that. Do we need perhaps a different method of pathways for rare disease? And also, when you think about rare disease, what about the others? So the chronic disease actually perhaps have higher financial long-term burden for the payers. So what are the incentive, as Sabrina was saying, that what might be the incentive for the company perhaps to develop this kind of product is chronic disease rather than all the focus on rare disease and oncology, which is high unmet need, but perhaps there are also certain disease areas that has higher financial implication. So I think that's all our research is around, to bring the stakeholder together to think about from development, what's the incentive to support the innovation? And then do we have a particular pathway and incentive through regulatory procedures, through like HTA decision-making to enable perhaps different flexible approach to review this kind of product. And this could be where Hong Kong could start. You don't have to do everything straight away. Maybe like on the European level, they start from oncology, then orphan, and then everything else. So maybe you can start from where it's most needed.
I'm not sure if you're gonna like this, but so look,
I love that
when you
beginning.
said that we can set up the threshold, and then if we want to, incorporate more innovation, we just put the number above. I think it's a very risky way of thinking. Why? Because we can set up the threshold very high. We just can agree with that. What is going to happen next? You're going to allocate more money to innovation. What is going to be the effect in industry? Not you guys who work in industry, but your investors. They're going to say, oh, there's a huge willingness to pay more for innovation. So I'm going to put more money, and you're going to put the prices higher and higher and higher. And that in the long run, that never ends, right? So, and what are the consequences of that? Is that you are allocating more money in that direction instead of the health system. And the waiting lists are going to be higher and higher and higher. So there is always a consequence in resource allocation. So that's why I said that the threshold is not something that you can move. It's a fact. It's what is happening today in the system. And it's a measurement that helps you to estimate the health outcome of a particular decision. Now, I'm not saying that I'm against innovation. Please, no. I like innovation. I would like to have the whole money of the world to pay the whole innovation industry is producing. That is what I like. But even if we are thinking about that, we need a healthy environment for innovation. Because otherwise, all innovation is going to go higher and higher and higher, and the prices are going up and up and up. And this is what has been happening in the last decades. The prices are higher, higher. And you colleagues who works in industry are facing the challenge of having new launches with more products, very good products, but higher and higher and higher prices. And who is going to pay that? The cost of that is other services that are going to be displaced in the health system, right? And we're going to, stop making an early diagnosis of cancers, and we're going to end up diagnosing cancers after in stage 4, and we're going to have more demand for innovation again, and the prices are going to go up and up and up. Never ends. That is the problem. And that is not healthy for the system. It's not healthy for industry. It's not healthy for us as individuals and as a population. Sorry for this, right? But this is actually what is going on, right? So we need a healthy industry. We need healthy health systems. That is what we need. So we need to discuss, the next generation discussion is about how we can use HTA as a shaper to provide the good incentives for first industry to produce high value products. And high value means that good benefits, but at affordable prices. And what is an affordable price? Is a price that health system can pay without leaving behind the other needs that the system has to attend for the population, right? Actually, it's a very good idea to do preventive activities to avoid, spending money in dialysis, let's say, because that money could be used for innovation in rare diseases or cancer or whatever thing. But now, if we go, derivate the whole money into that direction, we forget about, what is going on with diabetics people, hypertension, and the kidney disease is going up and up and now, and now we're spending a lot of money in dialysis and whatever, and less money for innovation. So that is the problem. It's a global problem. And HTA gives us the opportunity to put things in the right direction. This is why we need to work together, industry, systems, society, to understand that this is a global problem and we need to shape the thing in a different manner.
Can I say a little bit?
Thanks for the very powerful message. Yeah.
I have some different views. Yeah, different views. Yeah. First of all, when we talk about innovation, means we have to drive a higher price for healthcare. I have a very different view because you even mentioned about opportunity cost. What if you don't use that medicine or you don't use that treatment? So treatment is not a kind of product. We can just, endlessly increase our price and neglect competition, neglect demand and supply, neglect, the entire healthcare system. And this is even in my industry, I have to say, openly to say, our price even with key reference to the GDP of the countries and the markets. So it is not an absolute price, But I do agree with you that we need to work together to maintain a sustainable healthcare system. This is very important. So what we consider is at the same time, why some price going up because the cost also going up. We have to ensure this is the sustainable innovation as well. So how to ensure a sustainable innovation and a sustainable healthcare system? It is not mutually exclusive. Actually, it is the key point. We have to work together. So, so this is why I would say we are not the cause of high price. This is not fair. Yeah. So, but I understand this is not you meant, But yeah, but I do think this is the point that we need to work together to ensure the sustainable and how to work together. This is one of the points. And HTA, our industry is not, we have HTA every jurisdiction. But the most important is we have to align what is the value framework within that healthcare system. That is very important. We have to align, all stakeholders, not only the payer and the industry. I think scholars, patients, we have to get together to align the value framework, to align the attributes within the value framework, what should be in, what should not be in, and to align the process as well, the calculations, the process of evaluation, and how to use the data. I think this is some alignment we can work together. And also, I think a real-world data could be very helpful to use a value-based and evidence-based calculation. And this is one of the reasons why Hong Kong U and we worked at the very beginning 3 years ago. We think about horizon scanning because we do think it is important first. Evidence-based, that's very important. The second is we have to be forward-looking. We are not, if we just solve the problem right now, I don't think we can really see the problem deeply. It is important to be forward-looking. We think about how to solve the future problem from now, but not at that point. But I like what you mentioned because it is very stimulating. This is also one of the reflection of our industry as well.
I think we have 10 minutes left, so I'm going to open it to the floor. Okay, Shirley, please.
Thank you, Victor. I'm so happy this forum or dialogue has been arranged, co-hosted by School of Public Health and School of Clinical Medicine. So we can share different perspectives. The first lessons we learn from health economic training is that healthcare resources is always limited. We have to use the resources smartly, strategically. And I think innovation is where we as a human stand, right? We do development, curiosity-driven, patient needs-driven R&D. That is it. I'm never against of any innovation. But I think the system actually have to smartly fund it. What do we mean by true innovation? We have to define innovation first, or the value first. Then we know it is an innovation. It is not something that we are going to compare Apple versus pear, not even Chanel versus other handbags, right? So I think we have to define innovation first. And health economics, we're also making choices between different options. We're talking about opportunity cost, something foregone. So the selection of a comparator group, I think, is even more important than the value cost-effective answer ratio itself. I think we know what we are comparing is important. What is our choice on hand? That's important. So that's going back to the rare disease stuff. We have nothing to compare. Are we really still making such judgment? That's my. And for those already have a pipeline of innovation, innovative ABC, what are the true definition of innovation? Do we need more so-called innovation in this area? That's another question. And this is an ongoing research question. And thank you so much again for culture scan to this stage. And that's where we can further carry on to learn more about selection, priority, innovative medicine definition. Yeah. And we have to think this from a holistic system. Public health, screening, prevention is more important than treatment itself. I was trained in public health. So that's my learning of my PhD. Yes. Thank you, Manuel.
Actually, you already concluded it pretty well, but I'm just going to open up and ask, whether the floor has any questions for our panelists, and maybe we can take 2 or 3 questions before we wrap up. Yeah, please, at the back.
Thank you so much. This is Kay from Roche, and I fully enjoy the whole lectures, and it's definitely very impressive and give a lot of insights to all of us here. So my question is a little bit more practical, or maybe more directed to Shelley. Since you have a lot of experience working in Hong Kong, so I'd like to see if you have any top of the mind suggestions that what we can do immediately now, or some quick fixes that can improve the current access landscape here. Yeah, thank you.
Access, I think Tina gave you the answer. That's what I learned. I think Tina delivered the talk more than I expected. I think early preparation is important, and as Sabrina suggested, forward-looking. Now do it now. While you already prepare your dossier for regulatory or HTA submission, it might be a bit of late. While the stage of design your clinical trials, pivotal trials, make sure the quality is good, make sure you selected a proper comparator group, and you collected all those information for both regulatory submission and also HTA. That will definitely shorten your streamline of application. And also, although we don't have a so-called PRO, patient reported outcome algorithm in the system yet, but I think it's on top of that, if you have such elements, that will be additional bonus. That's my general suggestion.
Thank you.
I hope I answered this question.
Yeah.
From scientific perspective, because the value flower is a whole framework. It's not only something as a single factor. Yeah.
Do we have any further questions? Yeah, over there.
Hello, my name is Sylvie. Thank you so much for the very insightful sharing. So I heard a lot of discussion about rare disease. This is very close to my heart. And I would like to bring up another question and hopefully gain more insights from you. So talking about rare disease, we always know the patient number is very few, but for Hong Kong, it's ultra few. For some disease, we only have a handful of patients, and there's no new case in 5 years. So for these kind of rare disease with innovation, is there anything that we could do? Because HTA, it seems that we know it takes time. It also takes quite a lot of money to commit after the research to bring the product to Hong Kong without definition was rare disease. So many of these small farmers are facing huge challenge on this journey. So is there any practical method that we can start embarking on this HTA journey in Hong Kong?
I can share the experience I had in Chile just before I came over here. For rare diseases, you're absolutely right. There is a problem of the evidence sometimes with a lot of uncertainty, temporal uncertainty. In gene therapy, for example, we have the promise that a particular disease is going to be cured, but we need to wait until, well, and see what happens actually. So one way forward is what we implemented in Chile, in Argentina, for Zolgensma. You might be aware about Zolgensma for muscular atrophy, very high cost drug with a lot of uncertainty. So we implemented a performance-based risk-sharing agreement, right? So basically, if we as a system, we want to pay just for the value, but the value we need to see what happens in the future. So we apply the drug and we see what happens in 1 year, 2 years, 3 years, and 4 years. This is the agreement there. So, and the agreement either in Chile and Argentina between governments and Novartis, which is the company behind of the drug, is like you pay kind of 20% of the first payment, and then if the outcomes, you see the outcomes, the expected outcomes in a year, another 20% and so forth, up to 4 years. That is the scheme. So you make sure that you're paying for the results that you expect, and you are not paying for those patients. So you make a better use of the limited resources, and that is, now in Chile, we did something similar for pembrolizumab, for breast cancer, and others, right? So this is one way to face the immediate problem we're facing.
Thank you. I would like to add a little bit more. First of all, Manuel's views is very correct, but at the same time, the most important is Hong Kong has no rare disease policy. This is the fundamental problem. So it is very difficult for us to create something, particularly for rare disease or orphan drugs. For example, whether we can use normal regulatory process to tackle rare disease orphan drugs. Definitely cannot, because we may not have phase 3 clinical trial or enough people to do so, right? You know, a lot of rare orphan drugs actually, is still in developing stage. And at the same time, because of that, the regulatory route, we cannot bring in a specific regulatory route for orphan drug. Because of that, we cannot have a specific treatment or some, for example, some innovative funding model for rare disease because we don't have a policy. This is why I think immediately and fundamental is we need a rare disease policy in Hong Kong in order to tackle the patients' access to the medicine, the affordability of patients, all kinds of things.
I would like to add onto that. Thank you so much. I totally agree. These are all the very practical way out for the rare disease. And one of the last challenge that I want to share with you, many small farmers actually want to skip Hong Kong. I've helped a few patient groups to try to get the drugs into Hong Kong, and they are not interested. So I feel the urgency is there. So thank you so much for the great mind, because I think this is the way to go. Thank you.
Thank you. I think we can afford maybe one last question if anybody has it. Or if not, then, well, I think, then thank you very much. And I think we have a great panel discussion, and thank you for the and very enthusiastic discussions as well. I think the message is clear, right? We absolutely need that a better system, a better health tech assessment mechanism. And to build that, we need all sectors to come together, right? From academia, from corporate, from government. So I think let's go on and work together, and hopefully, towards a better, more sustainable healthcare system that really attracts and all those drugs to come to Hong Kong, don't skip Hong Kong, and to actually and ultimately benefit the patients in Hong Kong, including rare diseases and all the other. So thank you very much again for the time, and let's end here. And well, I guess we will be staying around for a couple more minutes. So if you have any questions that you want, yeah. Yeah. Oh, okay. Yeah, we have a souvenir session. So please, Shirley.
I think on behalf of Hong Kong UMed, this event is co-hosted by School of Clinical Medicine and School of Public Health. So thank you again for all the guests and speakers, particularly Tina flying from London just for this talk. Thank you so much. So we're going to show our souvenirs. Manuel and I is going to be the representative to show this to Sabrina, Victor, Tina. Thank you for your very enlightening talks.
Yeah, thank you very much, ladies and gentlemen. Yeah, please join me in giving a warm round of applause as for those speakers. And how about we can have a big group photo together before we go? Yes.
And by the way, there are some advertisements. Give us feedback. I think feedback is important to make improvement. So you may receive our email for feedback about today. And next year, our SCAN seminar is still ongoing. So next year in September or June, we're planning another round of public talk and also forum. Please let us know what type of topic that will interest you. We're going to invite the best speakers to join us to stimulate more discussion. Thank you.
Ready? 1, 2, 3. One more. Ready? 1, 2, 3. Thank you.